otitis media. All right? The ends of the background, our aim is to assess the efficacy. Why do I have this one?
Oh, sorry, I switched them off. It's up on the thing again.
Okay, efficacy. What's the best way of determining efficacy?
Intention to treat.
Anyone else?
Modify.
With confidence, like you mean it.
Modify.
Efficacy of antibiotics, right, for otitis. More or less what that is? Right. Okay, efficacy. In order for you to determine efficacy, the patient has to be on the drug, right?
Yeah. Modified intention to treat.
You have to be on the drug.
Protocol.
So if you're on it, you're completing on the drug, right?
Yes.
So usually safety and efficacy, the best way to determine is per protocol, because you have to be on the drug in order to see if it's effective in the patient, if it's safe in the patient. If you just do a treatment failure and use modified intention to treat, you kicked out 10 people for whatever reason, they withdrew. Now you have a modification. Those 10 people are automatic treatment failures. How do you know if the drug is safe in those 10 people? How do you know if it's effective? You don't. They're gone. It doesn't make sense. You have to use the people that completed and took the whole course of the drug to see if it's effective in them, if it's safe.
Okay.
Yes?
How are you going to see it a lot of time? The safety is definitely a per protocol, but with efficacy, right? You want to, what is typical?
Modified intention to treat. But the best way would be per protocol, but most of the time it comes in modified intention to treat.
Because what happens with per protocol?
It's kind of hard to actually.
It's hard to do.
Not
Cannot
enough
be
power usually with per protocol due to all the people dropping out. So they use this one to meet power, even though this one per protocol is the best for that.
Okay.
So you would be modifying to treat instead of per protocol.
This is
And
typical. We'll look at the article now, but
Uh,
just when you see this, okay, the best thing they could use is per protocol. If they're using something else, it's usually because they want to meet power. Right? Okay, so that's the aim. They did it in the children. Hypothesis. Augmentin would reduce the risk of treatment failure versus placebo. Yes? That's the hypothesis. So, they're comparing Augmentin versus nothing. So what type of trial do you think they should use? It's not superiority, right? Because to be better than nothing is kind of pointless. You agree? It's not non-inferiority because you don't want to be no worse than nothing. You don't want to be equivalent to nothing. Right? Okay, so what type of trial? Study design. This was a randomized, double-blind, placebo-controlled study initiated. Randomized, double-blind, placebo-controlled. So they're just comparing two groups.
No, they're comparing against placebo.
Right. Placebo versus the drug. So it's a randomized controlled trial, but it's not superiority, it's not non-inferior, it's not equivalent. We agree?
Yes.
Okay, let's move on.
Makes sense, right?
Yeah, I don't know what else.
Okay, so placebo was similar to the active treatment in appearance and taste. That's good, so that they're not aware of whether they're on the drug or not, right?
Mm-hmm.
Parents were given a diary and were asked to record symptoms, doses of study drugs, all the things the child went through as they're taking the drug. Any questions so far? I'm going fast and I'm moving on to the next one. Okay, so right at the end before outcomes, it says at any visit, the physician could switch the study drug to rescue treatment of the child's overall condition or otoscopic signs warranted the change. Parents were encouraged to keep their children in a study for follow-up. Okay, so that's ethical, right? Something's going on with a child, you want to save them.
Yes.
And they're using a different drug, not, for example, if they're on placebo, they're not going to use Augmentin to save them, right? Okay, primary outcomes. How many are there?
6.
6 primary outcomes. 6. What is that known as? Composite. So you have a group of outcomes in order to determine the efficacy of Augmentin, right? They state all of them there. Right after the last one, it says the time of treatment failure was the study date on which the study physician confirmed any one of the components for the first time. Okay, one of my questions when I read it, it says here, whenever the physician sees the kid and says, okay, yeah, he's not looking good. That's
Yeah.
when
If it's in
the
a
treatment failure. But, for example, let's say your child on Friday night at 8 p.m. doesn't look so good and you wait till the next day to the physician to see him, could that influence maybe? Is that reasonable, Dr. Miss?
What is your question from that?
It is not accurate.
Could that introduce bias since you're like taking an extra day to confirm the diagnosis?
What is the purpose?
The efficacy.
And how
What
do you,
if,
how
for
are you
example, on
measuring
day
it?
3, the child is not looking good at night, you wait an extra day, maybe an extra 2 days to get to the doctor and the physician to see him. And then it's a
But
treatment
you have
failure
to
on
think
day
about,
5.
but you have to think about, for the purposes of the study,
Okay.
right? It's not like normally in a hospital where you literally could be laying in a bed and nobody will see you for 8 hours, right? In a study, they're looking at them a little bit more closely, right? So what is the statement that you read the
The
sentence?
time of treatment failure was a study day on which the study physician confirmed any one of the components for the first time.
And how many components are there?
6.
So-
any one of the things, any one of the 6.
So the child may or may not be running a fever, but they have one of those other composites wrong, then the physician will consider them failure and then give them some sort of rescue. Okay?
Okay, statistical analysis. 260 patients, 90% power. It says absolute reduction of 15 percentage points. Everyone with me so far? In the rate of treatment failure in Augmentin compared with placebo, assuming a 25% rate of treatment failure in placebo. How do they get to this 25? 25% treatment fail in placebo. How do they get to that? How do they see?
Oh, you're actually asking. Okay,
Yes.
so in placebo, do you expect resolution? Do you expect otitis media to self-resolve in some cases?
No. But why wouldn't it be like 50% instead of 25 or what? How does
Well, because otitis media can self-resolve. It can work itself out, right? Because what is otitis media? Is it a bacterial infection?
It's an ear infection.
Is it a bacterial infection? Right, we know otitis, right, is the ear, but is this a bacterial or viral?
Could be
Bacteria.
Could be either one.
Bacteria.
Okay, so do bacterial infections and viral infections, can they self-resolve?
Yeah.
Okay, so in a disease state where it can self-resolve, right? You assume that there's also going to be an absolute failure in placebo, okay? So they assume that 25% of those patients are going to get worse, right? That they're going to probably have to get rescue therapy, right? Or they may be removed from the study. So 25% of that group is going to come off as a failure, okay? So it has to be an absolute reduction of 15%, but you need to think about the fact that if you're going to have a 25% failure, right, then those aren't going to reduce, right? So you have to really, when they're planning this study, they need to make sure that they have enough patients in there randomized to placebo and to the active arm, and they need to make sure that they account for there's already going to be a 25% failure in placebo. So
That's
it's just,
why- That's why they enroll 320, right? That's why they say that we want to enroll 320? Okay.
But then, does that include like the kids who like are pulled out for like unethical reasons?
they're just saying that because how many do you need to get power?
260.
And how many did they,
Enroll
Analyzed
320.
319.
they enrolled?
Assuming a 20% withdrawal.
Right, so they know they're going to drop some, so they want to enroll a bunch to see if they can make sure that they get 260 randomized, right? And so they need that 260. So if they start with 320, they're going to randomize a little bit more than that, right? More than 260, because 260 is what you have to end with, right? So they need to have somewhere between that 320 and 260 because they know there's going to be some failures and they know there's going to be some dropouts, and that's why they play with those different numbers to see how many they actually need in order to end up with this. And that's why they use programs to determine how many they have to have randomized or how many they have to have in order to do that, right. So it's just talking about they're assuming that there is going to be a 1/4 of all those children are going to be classified as a treatment failure. And that can either mean they get worse, they get withdrawn, or they get rescue therapy.
Makes sense.
All right, any other questions on this? Pretty sure we got it go now. But just one more thing at the end, it says, all analysis performed, intention to treat. Even though this is typical, they're using this one, why do you think? We just talked about it.
Because
Not so much to disguise, to
couldn't
be
meet
power.
Yeah.
Right, the 320, the withdrawal, you need to get to 260. They're
Yes.
using this when they should really be using this.
So they use an intention to treat.
Yes, it says it at the last paragraph, right before the results.
But
All
they would-
analysis,
they would still have enough people if they use the modified. But they just report it wrong. That's all. Cause
And actual table, what are they using?
it says that in the analysis, they used 161 from the treatment and 158 from the placebo. So that's 319. So they still have enough to make power, but they just say that they're using it.
That's intention to treat numbers.
Those are not modified.
That's
Yeah, that's
modified.
intention to treat number.
wait,
The
there's
last
something,
box?
there's something weird about this one.
Because
Yeah.
if you look, it says they did not receive treatment
It's
and they
intention
did
to
not
treat.
receive any follow-up visits for the 161.
She's talking about the last box.
The last box is intention to treat.
Yes.
No, it's modified.
No, it's not
No, the one
modified.
person that dropped out, they didn't receive anything.
What
Yeah,
is your
but the other
intention to
ones-
treat numbers?
Oh, the ones that received treatment,
160 is our intention to treat
modified.
number.
And so what's the one at the bottom?
Modified.
158.
So is that intention to treat? What is intention to treat? We just asked this. What is intention to treat?
160.
And what do you have?
158, so.
So can that be intention to treat?
No.
Okay.
It's modified.
Oh,
So why do they tell you
they're going to tell you something?
all analysis were performed on data from the intention to treat population?
Why?
Then in
It's
the figure
weird.
1 it says 161 and 158, which is modified intention to treat, were included in the analysis.
It's weird.
It's weird, no, they're deceiving you.
Yeah.
It's not weird
The
anything.
weird part is that they still have enough, if they said, I don't know.
Everybody agrees
They
that
may
once-
go back and use 160 and 160,
162.
62 and 160
which is-
to do their calculation numbers, right?
Mm-hmm.
But what do they tell you at the bottom of your figure 1?
161 were included in the analysis, 158 were included in the analysis.
Okay, so you know there's a discrepancy in what is considered the intention to treat number.
So in reality, they're using modified?
Well, are they using intention to treat?
No.
Okay.
So then they're just saying the wrong term?
Yeah.
They do that?
Why would they do
I
that?
have, why would they do that? Before we end this, I have one quick question.
Because your numerator is bigger in intention to treat.
Okay.
So what's that going to do?
Make it look better.
Oh,
One question before we end. If you go to the Kaplan-Meier curve for this one, I don't know, maybe it says that you start at 161 for times treatment failure, and you end up with 130. But they said they lost 30 people to treatment failure. It should be 31, no?
Where do you see? Where are you?
Kaplan-Meier curve?
Okay. At the bottom?
Yeah.
what is that? There's a little dark heading that says right what you're talking about so people understand what you're saying. It says NO at risk.
Oh, number at risk.
Okay.
Number at risk, sorry. Sorry. Do you know? Or... It's weird,
Okay,
So which one?
Kaplan-Meier curve, right? Number at risk. So for augmentin, they started at 160. They ended at They started at 161 and they ended at 130. Correct?
Yeah.
And you're saying there's only 30 treatment failures as opposed to 31?
That's how they report it. They says that occurred in 30 of the 161 children. That's how they report in the results, but this, I don't know.
Treatment failure occurred in 30 of the 161 children who received augmentin. And that's how it's shown in figure 3 as well, 30. I think in figure 1,
But one did not
in figure 1 at the end, how it says 161 were included in the analysis. 1 was included until withdrawn by parent on day 3. Maybe that's
Oh,
your,
is that the, yeah?
I'm thinking that's it.
Okay.
Yeah.
And
Yeah.
the rest of the 30.
Yeah,
Dr.
okay.
Garcia smiling to confirm.
Okay. Okay.
All right.
Yeah, quick question.
Yes.
Which one do you determine, is it the intention to treat or the modified intention to treat to determine power in this study?
To determine power, they said intention to treat, right?
But they actually did.
They're using what the modified.
But they actually use modified intention to treat in the analysis.
So which one do we use?
I don't know, you tell me.
Do we use the modified intention to treat?
There's something wrong if they're using one and saying the other, right?
Exactly.
Okay.
So ideally you should use modified, but they use intention to treat to make it look better.
Yes.
I think that's all we're supposed to get out of it.
Yeah.
Anything else you want to review or go over?
Data is,
Okay, figure 3, quickly. Absolute reduction. Notice how there's a 0. We went over this before, right? 0, absolute reduction. So the first one, treatment failure. 30, augmentin, 71, placebo. So there is an absolute risk reduction in treatment failures by using augmentin versus by using nothing. You guys see that?
Yeah.
Okay.
Because it's what? Because it crosses the line, doesn't cross the line?
Doesn't cross the
It does
line.
not cross the line
Okay.
of 0. So it's,
So you can just hold on to.
okay. So in figure 3, the very first one, treatment failure, 30 in the augmentin group versus 71 in placebo. There is a significant absolute risk reduction by using augmentin versus placebo. This is confirmed by the fact that this line is not crossing the 0. It's way over here. Yes? Treatment
Yes.
failure.
Oh, okay. Yes.
Anything else you guys want to review before we end this one?
They use high score tests, student tests, categorical.
Somebody had asked a question in the discussion part of this article. They mentioned superiority of augmentin to placebo. Can these truly be called superiority trials if you're compared to placebo? I think we talked about it earlier. You don't want to be superior to nothing. Well, you do, but you wouldn't do a superiority trial versus placebo. So you're just comparing two different groups, a placebo versus a drug.
Now, would they ever say that it's superior if
Yeah,
they
they
didn't
say
do
that.
a superiority trial?
Yeah.
Yes, they only want to make it look better.
So all they can really say is that augmentin significantly reduces, but
They
if
should
it's not
say.
designed as a superiority trial, you cannot say that it's superior.
But can they say that?
They can say it, it's just not true. It's just doesn't match the design of the study. Yes?
Yes.
Yes, Dr. Garcia?
Yes, she's smiling again.
Because they didn't claim it. They were
So they just
claiming-
compare it
If you're
to-
doing superiority, you can only do superiority and that's it. If your study design is for comparison, you can't say I'm superior or I'm not any worse than that. You can only claim what you're designing your study to do. I'm comparing two groups, okay, mine is statistically and clinically significant in terms of efficacy in otitis media. But I cannot say augmentin is clearly superior because I didn't design my study that way. We all agree? She is cheering over there.
Yeah, but isn't the study showing that augmentin is superior than the placebo?
It is showing that
Okay.
augmentin is statistically and clinically significantly better, right?
That's right.
Based on all of the facts and the stats and everything going on. Yes, it's showing that. Any other questions on this?
No.
We're good on this one. Supposed to